I think the 6 is related to today's topic, so I think so we should start from this, then move to 7.
Okay, question number 6. 27, yeah, this one, right? A 27-year-old African American comes to the office due to 6 weeks of pain and swelling of her hands and wrist. The pain worsens in the morning and is associated with stiffness for 10 to 15 minutes. She also has had easy fatigability and muscle aches. The patient has no significant medical history and does not take any medication. She has been sexually active with a new partner. Temperature is 37.9. Blood pressure is 140/90. Pulse is 76. Physical examination shows slightly swollen tender metacarpophalangeal and proximal interphalangeal joint. There is a non-tender ulcer on the buccal mucosa. Mid-cervical and axillary lymphadenopathy are present. Cardiopulmonary auscultation is normal. The abdomen is soft and non-tender. Lab results are as follows. Hemoglobin 11, platelets 90, leukocyte 4,500, X-ray of hand and wrist reveal no bony erosion. Urine analysis shows 2 positive, protein 20 to 30 red blood cells. Which of the following is the most likely diagnosis? Behçet's disease, disseminated gonococcal infection, Fallot syndrome, Hodgkin's disease, parvo virus, B19 infection, sarcoidosis, and SLE. Okay. So yeah, everybody give answer, either right or wrong, but everybody should answer. Okay, so
Okay, in chat, some are saying sarcoidosis, and
okay.
2 said Hodgkin disease.
Oh well, I cannot see the chat. Okay. So okay, let's look at the main points, like 6 weeks of pain and swelling for hands and wrist. Okay, easy fatigability and muscle aches. Okay, temperature is high. Yeah, and there is a non-tender ulcer on buccal mucosa, right? Is there any eye findings? No. Okay, there is a platelet count is low, hemoglobin is low, and there is a renal involvement. Okay, I would most likely go with SLE. Okay, the reason why I'm not selecting the Behçet's disease, because Behçet's disease has arthritis, oral ulcer, but there is uveitis in the Behçet's disease. But in SLE, there is like renal involvement, the blood cells, and the positive protein. Plus, this is a chronic condition and like all the symptoms. Okay, so let's move to the answer and see. So it's SLE, right? Okay, manifestations of systemic lupus erythematosus, constitutional clinical symptoms, constitutional fever, fatigue, weight loss, symmetric migratory arthritis, skin, butterfly rash and photosensitivity, serositis, pleurisy, pericarditis, peritonitis, thromboembolic event due to vasculitis and antiphospholipid antibodies, neurologic, cognitive dysfunction and seizure, lab hemolytic anemia, thrombocytopenia, and leukopenia, hypocomplementemia, C3 and C4, antibodies, ANA-sensitive, anti-DS DNA, and anti-SM specific, renal involvement, proteinuria, and elevated creatinine. Okay, so it's not necessary that all the things were present in the patient, like photosensitivity and this. Okay, this patient's fatigue, polyarticular arthritis, painless oral ulcers, thrombocytopenia, and likely glomerulonephritis, hematuria, proteinuria raised a strong suspicion for systemic SLE, a multisystem inflammatory disease, most common in young African American women. Arthritis and arthralgia affect 95% of the patient with SLE and tend to be migratory, symmetric, polyarticular, and accompanied by brief morning stiffness, much shorter in duration than rheumatoid arthritis. The knees, carpal tunnels, and joints of the finger are most commonly affected. Joint pain often exceeds the objective finding on examination, and X-rays usually reveal no evidence of joint destruction or erosion. Unlike other inflammatory arthritis, such as rheumatoid arthritis, other clinical manifestations of SLE include malar rash, serositis, pericarditis, neuropsychiatric complications, thromboembolic events. Lymphadenopathy often occurs as a primary manifestation. Okay, choice A, Behçet's typically present with multiple oral and genital ulcers that are recurrent and painful. Uveitis is common. This patient has a non-painful oral ulcer, hematological and renal abnormalities which are not typical seen with Behçet's. Choice B, disseminated gonococcal infection can cause a purulent arthritis or the triad of tenosynovitis, dermatitis, 2 to 10 painless pustules on the distal extremities, and polyarthralgia, thrombocytopenia, oral ulcers, and proteinuria would be atypical. Choice C, Falty syndrome is a potentially serious complication of rheumatoid arthritis characterized by neutropenia and splenomegaly. Recurrent bacterial infection is common due to neutropenia and may lead to lymphadenopathy. However, most cases occur in patients with long-standing erosive rheumatoid arthritis. This patient's short duration morning stiffness, normal joint findings on X-ray, and lack of splenomegaly make Felty syndrome unlikely. Choice D, Hodgkin disease can cause systemic symptoms and lymphadenopathy. It is also associated with minimal change disease and nephrotic syndrome. However, oral ulcer, synovitis, and glomerulonephritis, red blood cells on urine analysis would be uncommon. Choice E, most adults with parvovirus infection are asymptomatic or have flu-like symptoms. A minority may develop a self-limited symmetric non-erosive arthritis, but the prolonged duration of symptoms greater than 3 to 4 weeks and renal abnormalities, hematuria, proteinuria make SLE more likely in this patient. Choice F, sarcoidosis typically present with pulmonary and skin findings and can cause interstitial nephritis. However, glomerulonephritis and oral ulcers are unusual. Educational objective, SLE is a multi-system inflammatory disease that often present with arthritis and arthralgias. Joint involvement tends to be symmetric, migratory, and non-erosive with brief morning stiffness. The knees, carpal joints, and joints of finger are most commonly affected. Okay, now we have question number 7. Hina, can you read, please?
Okay, the question number 7 is a 32-year-old woman is brought to the hospital due to sudden onset of left-sided weakness. According to the family, she has fatigue, malaise, and decreased appetite over the last several weeks. She attributed these symptoms to a viral infection and treated herself with the over-the-counter acetaminophen. Her temperature is 37.4, blood pressure is 140/80, and the pulse is around 82. The patient appears confused and agitated. Lungs are clear to auscultation. 2/6 holosystolic murmur is heard at the cardiac apex. Extremity examination reveals left-sided muscle strength is 1/5 with hyperactive deep tendon reflexes. Babinski sign is present on the left side. Laboratory results are as follow. Hemoglobin, which is low. Platelets, again, it's low. Leukocytes also. Blood urea nitrogen is 18. Creatinine is 0.8. ANA is positive, and rapid plasma region is also positive. CSF counts are normal and cultures are negative. Which of the following is most likely the diagnosis of this patient? Antiphospholipid lipid syndrome, multiple sclerosis, neurosyphilis, and polyarthritis nodosa, and rheumatic fever. So rheumatic fever will not be there because she's not having any kind of fever. And any other symptoms associated with that?
It would be antiphospholipid syndrome.
Most probably it can be because see, we have hemoglobin is also low and ANS is also positive.
And she's had a stroke, so that's a thromboembolic event.
Yeah, also like we read today, like this one will be positive. No, but that was VDRL positive, right?
Yes, VDRL was positive, but ANA is also positive, right?
Yeah, ANA is also positive, so yeah, that goes towards the antiphospholipid.
And it's,
Multiple,
antibodies.
no. Yeah, because all other findings, I think, doesn't go with. Yeah.
Okay, yes, it's antiphospholipid syndrome. And antiphospholipid syndrome is venous or arterial thromboembolic disease, deep venous thrombosis, pulmonary embolism, and ischemic stroke, and transient ischemic attack. Adverse pregnancy outcomes is unexplained embryonic or fetal loss, premature birth due to placental insufficiency or preeclampsia. Lupus anticoagulant effect, paroxysmal APTT prolongation, not reversed from plasma mixing studies. Presence of specific antiphospholipid antibodies, anti-cartilipin antibody, and anti-beta-2 glycoprotein 1 antibody. Okay, this young woman with constitutional symptoms, fatigue, thrombocytopenia, probable mitral regurgitation, which was known as systolic murmur at the apex, and positive and suggestive of systemic lupus erythematosus, now likely has a CVA, sudden onset of unilateral weakness, negative CSF findings. She was having weakness also?
Yeah, she was
Yes,
having
one-sided
left-sided
weakness.
Yeah, having left-sided weakness.
So most probably it was because of thrombosis, right?
Yeah.
The biggest risk factor for APS is SLE. APS occurs in up to 40% of these patients. A minority of health individuals may develop transient antiphospholipid antibodies, so all the positive serology for APS should be repeated at 12 weeks to confirm the diagnosis. Patient with APS often requires anticoagulation for life, heparin, product, or warfarin, as the risk of recurrent thrombus is high. For those with SLE, hydroxychloroquine is also added. Choice A, multiple sclerosis with neurological symptoms, but transverse myelitis causing paraplegia and paralysis is much more common than hemiparesis. As MS is inflammatory, symptoms tend to develop over hours or days, not suddenly. MS also would not explain this patient's hematologic abnormalities, positive NA, rapid RPR, or murmur. Okay, hematological abnormalities she was having. Hemoglobin was low, this, and this was positive.
Okay.
Then neurocephalus can occasionally present with arthritis, arteritis, causing a cerebrovascular event in a young patient, but it is typically accompanied by abnormal CSF count. In patients with APS, a false RPR test is not uncommon, as the syphilis antigen used in RPR testing contains cardiolipin. Polyarthritis nodosa can cause a CVA in minority of patients, but mononeuritis and polyneuropathy are far more common. In addition, other findings such as arthralgias, myalgias, and cutaneous renal or gastrointestinal diseases are often also present. Rheumatic fever causes chorea-like movements. It is commonly present with carditis and migratory arthritis. Antiphospholipid syndrome is characterized by a thrombotic event or pregnancy morbidity in the setting of positive autoantibody to one of three phospholipids. Anti-cardiolipin antibody, anti-beta-2 glycoprotein 1 antibody, or lupus anticoagulant. It's very common in patients with SLE. So the key points to find over here in this MCQ was the weakness. She was having fatigue also, appetite, and it was not acute. It was not sudden. It was, it was chronic. And her blood pressure was also raised. There was a murmur also, and she was confused. And CSF was clear. And laboratory findings also show positive ANA, and hemoglobin was low, and everything was low. Okay, a 45-year-old woman comes to the office with knee pain. She has a long history of rheumatoid arthritis affecting the joints of her hands, wrist, and knees. The patient has mild residual pain and joint stiffness on low dose methotrexate, but has otherwise done well. Over the past 2 days, the pain in her right knee has been much more severe and was associated with an episode of chills. Temperature is 38, blood pressure is 120/70, and her pulse is 100, and respirations are 18 per minute. Physical examination shows mild swelling in the joints of the hands and wrist. The right knee is red and more swollen than on the previous examinations. Active and passive range of motion at the knee is also limited due to the pain. After appropriate diagnostic testing, which of the following is most likely to be indicated for this patient's current condition? Like what we should add next? She's already taking methotrexate, and she's responding to that also as well. So allopurinol, antibiotics, anticytokine, coachine, glucocorticoids, high dose methotrexate.
Glucocorticoids.
I think, see, she's having, the right knee is red, swollen, and she's having
Oh, yes.
chills also. So, and temperature is also
Septic.
raised. So I think so
Yeah,
she's having
so
some kind of infection.
yeah, right. Some septic, septic arthritis or something.
Yes, because she's,
So what?
rheumatoid arthritis she's having. And now, I
So
think so she's
could
having some kind
be,
of infection. And see,
yeah.
active and passive
So
range of motion is also reduced because of pain. So pain
mhm.
is also there, which is severe. So for me, I think so it will be antibiotics.
Antibiotics, yeah, I think so. Antibiotics. But septic arthritis, yeah, antibiotics or glucocorticoids. Yeah, I think antibiotics is like the best choice.
Yes, and
Yeah, antibiotics.
antibiotics.
Yeah, the answer is yeah,
Okay, this
septic
is
arthritis.
septic arthritis. Risk factors say abnormal joint, osteoarthritis, rheumatoid arthritis, prosthetic joint, gout, age greater than 80, diabetes, IV drug abuse, alcoholism, intra-articular glucocorticoid injections. Clinical features: acute monoarthritis, hot, swollen, decreased range of movements, fever, elevated ESR and CRP. These were the, you know, findings which is we just saw. Fever was there, knee was there, hot. It was your knee was involved. It was hot, swollen, and the range of movement was also reduced. Okay, the diagnosis is blood culture, synovial fluid analysis, which will show leukocytosis and gram stain and culture. Initial treatment is gram-positive cocci vancomycin, gram-negative rod third-generation cephalosporins, negative microscopy vancomycin plus third-generation cephalosporin if immunocompromised. The patient's clinical features are acute monoarthritis with fever, limited range of motion. Underlying rheumatoid arthritis are suspicious for acute septic arthritis. Septic arthritis is more common in patients with underlying joint abnormalities. Example, rheumatoid arthritis and osteoarthritis. Prosthetic joints or those who undergo repeated synovial glycocorticoid injections. Patients with rheumatoid arthritis are at easily high risk due to impaired phagocytosis and systemic immunosuppression. Occasionally, septic arthritis in patients with underlying rheumatoid arthritis may present without overt signs of infection. Example, fever, chills, peripheral leukocytosis. This is especially common in elderly patients and may lead to delayed diagnosis. So in older population, one can have septic arthritis, which can go unnoticed because they might not present with the typical features. Synovial fluid analysis should be performed to confirm the diagnosis and exclude other causes of acute inflammatory monoarthritis. Typical findings include elevated leukocytosis, positive gram stain, and positive fluid culture. Blood cultures are positive in 15% of the patients and should be obtained along with synovial fluid studies prior to antibiotic therapy. Treatment for septic arthritis requires prompt administration of IV antibiotics and adequate joint drainage to lessen the likelihood of the destruction. Septic arthritis is characterized by acute monoarthritis, often with fever, and restricted range of motion. It is more common in patients with underlying joint diseases. Synovial fluid analysis should be performed promptly to confirm the diagnosis. So this might be the picture for the synovial fluid. Might display something like this. Okay, question number 9. A 51-year-old woman comes to the office for a follow-up visit. The patient was initially evaluated 3 weeks ago for bilateral wrist and hand pain that had been occurring for 2 months. She was prescribed ibuprofen and now reports satisfactory improvement in the symptoms. Medical history includes obesity, hypolipidemia, and major depressive disorder. She is post-menopausal. The patient occasionally drinks alcohol but does not use tobacco or illicit drugs. Vital signs are within the normal limits. Physical examination shows decreased swelling and tenderness of the bilateral wrist and metacarpophalangeal and proximal interphalangeal joints compared to 3 weeks ago. Okay, laboratory studies show the erythrocyte sedimentation. ESR is 52, and anti-citrullinated peptide antibodies are positive. Low-dose methotrexate therapy is planned. Obtaining which of the following is most appropriate prior to starting the therapy in this patient. So what we have to do before starting this low-dose methotrexate: comprehensive ophthalmological evaluation, glucose 6-phosphate dehydrogenase level, interferon gamma release assay, liver aminotransferase levels, transthoracic echo.
I think LFTs.
Yeah, liver aminotransferase levels. Yeah, I think so, Safin.
Yeah, because they want to
Why?
start the methotrexate. Because for the methotrexate, we read it when we start the methotrexate, we monitor the LFTs.
Okay, so it might be D. Yes, liver aminotransferase levels. So this is DMARDS. Methotrexate mechanism. Okay, fine. We are going to start methotrexate, and the adverse effect is hepatotoxicity. So we will check the liver function test. We will do LFTs to know the liver status, stomatitis and cytopenias, and these are the other drugs which we can give, and these are the side effects. So leflunomide, hepatotoxicity, and cytopenias. Again, if this was given, then we will go for hepatotoxicity. And hydroxychloroquine, then this retinopathy, then ophthalmic evaluation we will do. Sulfasalazine is hepatotoxicity, stomatitis, hemolytic anemia. Again, we will go for LFTs. And TNF inhibitors, infection, demyelination, congestive heart failure, and malignancy. The patient has rheumatoid arthritis presenting with symmetric polyarthritis affecting the metacarpophalangeal joints, proximal interphalangeal joints, and wrist, along with elevated inflammatory markers, that is C-reactive protein and ESR. The diagnosis of rheumatoid arthritis is primarily based on the clinical findings, but serological markers, example, rheumatoid factor, cyclic citrullinated peptide antibodies, can assist in the diagnosis and are associated with high risk of extra-articular manifestations, that is rheumatoid nodules. Patients with rheumatoid arthritis can be treated acutely with glucocorticoids, that is prednisolone, or NSAIDs, that is ibuprofen, but these treatments provide only symptomatic relief and do not alter the long-term destruction of rheumatoid arthritis. For this reason, DMARDs, which improve long-term joint dysfunction, are initiated as soon as practical after diagnosis. Methotrexate is preferred the first-line DMARD and most common in the patients with rheumatoid arthritis, and it causes hepatotoxicity, which can range from mild elevation in hepatic aminotransferase to chronic liver disease and cirrhosis. Serum liver studies should be checked prior to initiation of methotrexate and periodically during treatment. Patients should avoid alcohol intake and methotrexate therapy for rheumatoid arthritis associated with hepatotoxicity. Serum liver studies should be checked prior to initiation of periodically thereafter. Much of Okay, so we were here. Methylphysic therapy for rheumatoid arthritis is associated with hepatotoxicity. Serum liver studies should be checked prior to initiation and periodically 3 years after. Much of the toxicity of methotrexate, including hepatotoxicity, can be mitigated by concurrent administration of folic acid, which does not reduce the effectiveness of the drug. So we have to give folic acid together with methotrexate whenever we are going to prescribe methotrexate. Okay, the question that was causing the confusion was this one, the SLE question. So if anyone has the values in MMQ, please share because I'm confused in these values. Like you were saying that it's a thromboembolic event. So how come do you get to know that, there is some kind of thrombosis happening? Because the weakness, but if we see if according to me, what I think is this platelets are low. So low platelets will cause thrombosis. Because I searched online, I was not getting the values of the platelets and all implements. MMC, it was. I just go with the.
No, actually, the thrombosis is not because of the low platelet, because of the antiphospholipid.
See,
Because
okay.
antiphospholipid, there is vasculopathy, which leads to this thromboembolic events. The vasculopathy means the vessel walls are not good. So when the platelets are getting into those vessels, they are like getting stacked up, like forming a thromboembolic, like gathering together, and due to which there is thromboembolic
Please
events
repeat.
are happening.
It is not because of low platelet values, but because of what? The shape,
Vasculopathy, because of
vasculopathy.
in antiphospholipid syndrome there is vasculopathy going on.
But
Due to
here,
this vasculopathy,
they didn't mention any such thing, any antibody, or only just Anna was positive.
so ANA is the thing for the antiphospholipid, SLE basically. So antiphospholipid is like the variant of SLE. So ANA means this patient is having SLE going on, and the antiphospholipid variant of the SLE.
Okay, so I just read it here. Okay, fine. Yes, suggestive of SL. See, we are given these features. This
They said with
okay. The
thrombotic
patient
event.
of SLE can have APS as well. Given these
Even
features,
today, in the today, like when we studied this antiphospholipid, so yeah, it's like a variant of SLE. They said like in SLE, then we can have APS.
so I was just
Sign and symptoms of SLE, in this they mentioned that. And normal values can only
okay.
a
Anna is
person.
98% sensitive. We will get Anna
Hmm.
in SNE and treatment. Okay, fine. And in antiphospholipid,
See the same investigation.
the secondary APS. Okay, fine. It
Hmm.
occurs in the setting of connective tissue disorder, that is the SLE, malignancy and drugs. hydrogen
Yeah,
and
and the
everything.
second
And
thing,
yes.
there is thrombocytopenia, but there is increased risk of clotting and increased APTT in antiphospholipid antibody syndrome. Increased APTT, activated partial thromboplastin time.
That means the bleeding time is prolonged.
No, activated
Okay.
APTT,
APT, okay.
yeah, thromboplastin time.
Okay, we will be having thrombocytopenia in antiphospholipid, okay? And
Almost in
AP,
every condition, in rheumatoid arthritis also, in SLE also, in this antiphospholipid antibody syndrome also, because autoimmune, so just there could be a like chances of pancytopenia.
and APTT will be high or low.
Yeah, high. Antiphospholipid antibody syndrome, APPT, high.
Okay, question number 10. A 35-year-old man comes to the office for follow-up of low back pain. He has aching pain in the left lumbar paraspinal area that is worse at the end of the day and is relieved overnight with rest. The pain began 3 months ago without any precipitating trauma. The patient was initially treated with intermediate doses of acetaminophen and naproxen, but continues to have moderate residual pain. There is no associated fever, weight loss, particular pain, lower extremity weakness, or urinary symptoms. His medical history is unremarkable. The patient is employed as a factory line worker, which requires him to lift 5 to 7 kgs several times a day. On physical examination, vital signs are normal and the patient appears comfortable. Cervical and thoracic spine range of motion is normal, but flexion and extension of the lumbar spine resists pain. Straight leg raising test is normal. Um, there is mild tenderness in the left lumbar paraspinal tissues, but no midline tenderness. Upper and lower extremity strength and deep tendon reflexes are normal. Which of the following is best recommendation for the management of patient's pain? Discontinue working until the pain is resolved. Epidural glucocorticoid injection, exercise therapy, lumbar support brace, and spinal manipulation therapy.
Is it ankylosing spondylitis? Looks like ankylosing spondylitis. I think glucocorticoid injection.
What will be the management? Like what we will do? We can't discontinue working until the pain is resolved. No.
No.
Epidural glucocorticoid injection He is having left lumbar aching pain and left lumbar paraspinal area. Exercise therapy.
I
Lumbar
think exercise
brace.
therapy.
Lumbar brace will also not be the answer. Spinal manipulation therapy. This I have no idea what it is. Exercise therapy. I think so. We can start with some kind of exercise therapy because see, the pain is worse at the end of the day and it's relieved overnight with rest. It means it's because of maybe kind of muscle
Degenerative
spasms.
condition,
Yes,
not inflammatory
and
condition.
the man is also young. He's only 35 years old. So and it's low back pain. There is no radiation. So the patient is employed, factory worker, lifting pain, physical examination, everything is fine. Cervical and thoracic range of motion is also normal, so no brace. And but this flexion and extension of lumbar spine electric pain. So I think so we can go with exercise.
Yeah, okay. Let's see.
Yes, it's exercise. So it's the
Exercise
management of low back pain, acute pain less than 4 weeks. We do maintain moderate activity and sets of acetaminophen. Consider muscle relaxant and spinal manipulation. Any idea what is this spinal manipulation?
Okay, I Googled it. It says spinal manipulation is an intervention performed on spinal articulation, synovial joints, which is asserted to be a therapeutic. These articulations in the spine that are amenable to spinal manipulative therapy include Z-joint, the atlanto-occipital, atlantoaxial, lumbosacral, sacroiliac, costotransverse, costovertebral joint. National guidelines come to different conclusion with respect to spinal manipulation, with some not recommending it, others recommending a short courses in those who do not improve with other treatment.
Okay, so in easy words, what's spinal manipulation?
Wait, let me do ChatGPT. In easy words. It is known as chiropractic adjustment or spinal adjustment. Is hands-on healthcare technique primarily used by chiropractors and health care providers. It involves applying a controlled force to a specific joint in the spine, typically using the chiropractor's hand. The goal of spinal manipulation is to improve function of spine and alleviate various musculoskeletal issues, such as back pain, neck pain, and headaches. Imagine, okay, there is an example. Imagine your spine is like a stack of building blocks, vertebra, and sometimes these blocks do not align properly. Spinal manipulation is like gently nudging these blocks back into their correct position. This adjustment can help relieve pain, improve mobility, and promote overall well-being. It's done by a trained professional who use their hands to make these adjustments carefully. Okay, that's all.
Okay, subacute pain, which is 4 to 12 weeks, intermittent use of NSAIDs or acetaminophen, and or chronic pain, which is greater than 12 weeks. Exercise therapy, stretching, strengthening, and aerobic. Consider tricyclic antidepressant and duloxetine. Secondary prevention is exercise therapy and education. So this patient was having low back pain for 3 months, which is equal to 12 weeks. So greater than 12 weeks also, we just start with exercise therapy. Okay, if the pain is also more than 4 to 12 weeks, then it's also exercise therapy, and secondary prevention is also exercise therapy. Initially, for the acute pain, we will just give NSAIDs and acetaminophen, and we can consider muscle relaxants, because sometimes, you know, you have muscle sprains and everything. Okay, this patient has an uncomplicated chronic low back pain. Patients with acute low back pain should be advised to maintain moderate activity with short courses of acetaminophen or NSAIDs to provide pain relief. Most patients will have resolution without any additional intervention. However, those with subacute or chronic LMP, lower back pain, are more likely to continue to have recurrent or persistent pain. In patients with chronic lower back pain, exercise has proven to be beneficial in reducing pain and improving function. Patients often start with supervised exercise program that emphasizes stretching and strengthening of the back muscles. Aerobic exercise also useful. Subsequently, patients can transition to the home exercise program, which should be continued for long-term short courses of acetaminophen or NSAIDs can also be used. Some patients also benefit from tricyclic antidepressants, but opioids, benzodiazepines, and muscle relaxants are not advised for routine use because they cause dependence and addiction. Okay, so management of chronic back pain should include exercise program emphasizing stretching and strengthening of the back muscles and aerobic conditioning. Acetaminophen or NSAIDs can be used. Some patients may benefit from tricyclic antidepressants, but opioids, benzodiazepines, and muscle relaxants are not advised, but they were giving when there was chronic pain for more than 12 weeks. We can consider that, but it is not routinely given because, but we can consider it. Okay. A 75-year-old woman comes to the emergency department due to 1 day of severe low back pain. The pain started after lifting a turkey from the freezer and reverses with standing, walking, and lying on her back. Standing, walking, and lying on the back. She had no recent falls, lower extremity weakness, or sensory loss in the legs. The patient has a history of temporal arteritis, which was diagnosed several months ago and is being treated with prednisone. She does not use tobacco or alcohol. Her temperature is 36.7, blood pressure is 140/70, and pulse is 80, and respiration is 160. That's fine. Physical examination reveals midline tenderness with palpation or percussion of the lumbar spine. Midline tenderness with palpation or percussion of the lumbar spine. Ankle jerk reflexes are absent bilaterally. Knee reflexes are 2+ in both knee. Flexor plantar responses are present bilaterally. Muscle strength is 5/5 in both legs. Bilateral straight leg raises to 90 degrees does not increase pain. Which of the following is most likely the diagnosis in this patient? Ankylosing spondylitis, epidural abscess, no. Herniated disc, lumbosacral spinal strain, metastatic tumor, no. Multiple myeloma, spinal stenosis, vertebral compression fracture. Okay, she is 75-year-old woman.
Vertebral compression fracture because she is taking prednisone. Prednisone causes osteoporosis long term. She's taking several months ago.
Yes,
So,
and you know, she started,
vertebral.
and you know, it worsens with standing, walking, and lying on her back, which can also cause pressure.
Yeah.
And the rest of
Yes.
all her findings are fine. This except this ankle jerk are absent, and knee reflexes are 2+. Muscle strength
No,
is
that's
555.
normal.
Yes, that's normal. Everything is fine. Everything is fine, fine. And but she's having standing, walking, and lying on her back. The pain. Flexor plantar responses are present. Muscle strength is also normal. Bilateral, okay, this does not cause pain. Okay, so vertebral compression fraction, what's likely the diagnosis? Yes. Okay, clinical features of vertebral compression fracture: trauma, osteoporosis, osteomalacia, bone metastasis, metabolic, and patient disease. Acute low back pain and decreased spinal mobility. She was having this, lying on her back, no worsen, no. Okay, spinal mobility pain increasing with standing, walking, and lying on the back. This she was having. Tenderness at the affected level. Chronic painless, progressive kyphosis, and loss of stature. Okay, fine. Complication: increased risk of fractures. Hyperkyphosis possibly leading to protuberant abdomen, early satiety, weight loss, decreased respiratory capacity. The patient's presentation: acute back pain and midline lumbar tenderness after lifting, suggests vertebral compression fracture, which occurs mostly in elderly people. Risk factors for this includes trauma, osteoporosis, osteomalacia, infection, malignancy, and bone metastasis, metabolic abnormalities such as hyperparathyroidism. Patients with gradual onset VCF can be asymptomatic. However, an acute VCF can present with low back pain, which she was having, and decreased spinal mobility after sudden bending, cuffing, or lifting. She was having this, she lifted something, but was she having decreased spinal mobility?
Yeah, she's having a limitation because of the pain.
Where it's written? No, it's not mentioned here. It's mentioned, okay,
Not here.
prednisone is mentioned, walking, standing, and lying on the back is mentioned.
Walking, standing, and
Rest,
lying on the
everything
back
is,
decreased mobility, right? It's
sorry?
decreased. So the pain is worsening on standing, walking, and lying. So that is
Yes, only
decreased
this thing is,
mobility of the
yes,
spine. This is the decreased spinal mobility.
this, bending forward, bending, backward, that is not spinal mobility. Sideways.
No, not sideways, only flexion and extension.
This is what I thought, that flexion and extension might be the spinal mobility. But if you're saying this, then okay, it could be. And she is having this, okay, midline tenderness as well, which they mentioned below, that they will be having, the affected area will be having tenderness. Okay, examination can show point or localized tenderness at the affected level, as seen in this patient. The repeated VCF can lead to kyphosis and loss of stature. Okay, non-traumatic VCF is most commonly due to osteoporosis, which decrease bone density and increase fracture. Although metastatic cancer can cause this patient's chronic corticosteroid, which she was using prednisone use, and post-menopausal because of less estrogen status, make advanced osteoporosis more likely. Okay, so post-menopausal was also a key point, and prednisone was also. Okay, a vertebral compression fracture is common complication of advanced osteoporosis. Patient with osteoporosis can develop a compression fracture with acute back pain following minimal trauma. Examination show localized or point tenderness. Although neurological examination is typically normal. Okay, do you want to do any further, or we should stop? और करें कि रुके? Am I audible?
Yeah.
Okay, we will
Okay,
do this
as you
question.
like. Yeah, question 12. Okay, then.
Okay, we will do this last one. Okay. A 34-year-old man comes to the office due to low back pain, but still, I'm not clear about this SLE question. I have to now search about APTT because I have, I don't remember that high, because I think high APTT means uh, prolonged meeting. Because I remember,
No,
INR,
bleeding
PT,
time, bleeding
we
time
just
is
go for
different.
PT test and INR just to check the clotting time. This is what I remember. Maybe what I don't know. That if they are high, then it means the bleeding will stop at very in slow rate. I will search for that. But if you have anything, just share in the group. Okay, 34-year-old man comes to the office due to low back pain and tightness for the last 3 months. The pain is dull, has an aching quality, and has become progressively worse. It is worse at night and in the morning, but improves gradually during the day as he moves around. The patient has no recent injury. Medical history is unremarkable. He lives with his wife and does not use tobacco, alcohol, or illicit drugs. Temperature is 36. Blood pressure is 120/70. Pulse is 80. Examination shows no tenderness over the lumbar spine or lower extremity weakness. Straight leg raising test is negative. Which of the following is most likely accounts for this patient's symptoms? Decreased bone mineralization. Which of the following is most likely accounts for this patient's symptoms? Like the underlying cause. Decreased bone mineralization, inflammation at ligamentous insertions, ligamentous sprain, lumbar disc degeneration, no lumbar spinal stenosis.
I think this is ankylosing spondylitis because it is worse at night and in the morning improves with as the patient moves. So yeah, this looks like an inflammatory nature. So what is the pathophysiology in ankylosing spondylitis? Inflammation at ligamentous insertion. I think B.
Anyone else?
Yeah, I would also go with D. I don't know.
B. I'm saying ball. B ball.
Bull?
B.
I don't know. I'm just making a guess. But D.
No, see the age is 34. So I think the degeneration doesn't
Yeah.
go.
Oh, yeah. I'm sorry. I thought it was an old man. No.
Okay, it is B. Inflammation and okay, causes of low back pain. Mechanical, normal urological examination, paraspinal tenderness, muscle strain, disc degeneration, radiculopathy, radiation below the knee, positive straight leg raising test, neurological deficit, herniated disc, spinal stenosis, claudication, relief with leaning forward, Okay, inflammatory, worse with rest, better with activity. Sacroiliitis. Okay, so this was in mechanical, everything will be normal and paraspinal tenderness will be present and herniated disc. Okay, fine. And below the knee, radiation with there will be okay positive straight leg rising test. Can anyone just explain what is a positive straight leg rising test?
Later
Anyone?
on,
Inflammatory.
I'll share the video from the YouTube.
Okay, inflammatory worse with rest, better with activity. Okay. Metastatic
So it's like,
age.
yeah, okay. I'll tell you, it's like the pain in the back or the leg by passive straight leg flexion with the knee in extension. You'll ask the patient to lie down and tell him to raise the leg. If he's having pain, then it's a positive, straight leg test.
Okay, so what were the key points for the inflammation here? Past 3 months. Pain is
This one,
dull.
like the pain is worse at the night, and in the morning it improves gradually. Like inflammatory pain, they get better in the morning. Like with increasing activity, they get better. Degenerative pain, they are better at rest.
Like for the osteoarthritis and all.
Yeah.
Infectious, recent infection or fever and focal spine tenderness. Okay. Most low back pain is due to mechanical causes, that is muscle strain and ligamentous sprain. Improves with rest and usually resolves spontaneously over 2 to 4 weeks. However, this patient has symptoms of inflammatory back pain, which is characterized by the gradual onset of pain and stiffness that begins at a young age and which worsens with rest and improves with activity. Okay. It can be any inflammatory pain. It's gradual onset, young age, worsens with rest, and improves with activity. Typically, okay, spondyloarthritis and inflammatory arthritis of the spine. The most common spondyloarthritis is ankylosing spondylitis, which characteristically affects the sacroiliac joint and apophyseal joints of the axial spine. However, spinal involvement can also occur with psoriatic arthritis, reactive arthritis, and arthritis associated with inflammatory bowel disease. Okay, and spondyloarthropathies affect the sites of ligamentous insertion and eventually destroy the articular cartilage, resulting in progressive pain and stiffness. Examination findings are often normal in the disease course. However, patients should be assessed for spinal range of motion and tenderness at the sacroiliac joints and tendon insertion sites. Okay. Inflammatory back pain is characterized by gradual onset of pain and stiffness that begins at the young age, worsens with rest, and improves with activity. It typically suggests spondyloarthropathy and, such as ankylosing spondylitis, psoriatic arthritis, reactive arthritis, arthritis associated with inflammatory bowel disease. So we will stop here and we will continue tomorrow, inshallah.
Okay, Hira, I have this for you, like bleeding time and activated partial thromboplastin time. So bleeding time, actually it measures the platelet. Like there is a decreased platelet, then there will be increased risk of bleeding, prolonged bleeding time due to platelet function disorder,
Repeat
anything.
again, please.
Bleeding time, like it's supposed how long it will take to stop bleeding. Okay, so it is due to defect in the platelet function disorder. Okay, then activated partial thromboplastin time is basically of the factors. Remember, we studied the factors 8, 9, 11, and 12.
5, 8, yes, yeah.
Yeah, the coagulation pathway. It actually measures the time takes for a blood to clot after specific chemical activators are added to a blood sample. It also tell us the effectiveness of intrinsic factors, intrinsic pathway basically. They tell us about the activated partial thromboplastin time.
Okay. So it's because of the deficiency of the factors and everything.
Yeah.
So again, the bleeding time will be prolonged, no, isn't it?
Didn't well, when you're studying about the antiphospholipid syndrome, they won't mention about the bleeding time most of the time. The more focus is about the antibodies, ANA antibodies, and the active partial thromboplastin time. You see that the question they didn't mention. It's just like an additional information. Sometimes they can give you like, yeah, there's a prolonged APTT.
Okay, got it. Thank you for sharing. Just share if you have written it, then share in the group as well, okay?
Or,
Okay,
okay, I'll
then we will
start. If I find the video, then I'll show.
okay, then we'll continue tomorrow. Okay, she's saying the bleeding time will not prolong. Uh, okay. Okay, Dr. Aisha, you can also come to the chat box and clear my confusions. Okay, see you. Yes.
Yes, actually, the bleeding time is not going to increase. And regarding the APTT, why it is increased, the reason is that the lupus antibodies are like there are several kinds of antibodies, right? So they actually what they do is they increase the APTT because it's a test which is done like in vitro. So they what they do is they interfere with the phospholipid. They consume the phospholipid, they attach to it, and they make it prolong. So that's why that is a very like a hallmark or like, but most of the times when the phospholipid which is used in the laboratory, if it is like sensitive to the lupus, then we will see a prolonged APTT. So generally question, and if you see that there's prolongation of APTT and all the other characteristics of SLE, then it is SLE.
Okay, now I got it. Thank
Yeah.
you.
No problem.
Okay, so I'll end the meeting, okay?
And 60 point, course of intensity.